Vitis dance, and side-hand chorea. It was not until 1872 that the name has changed to Huntington's chorea when it was described by George Huntington. Later on, the name has changed from Huntington's chorea to Huntington's disease to reflect the fact that chorea is not the only important sign in Huntington. In 1983, Huntington disease was linked to the photochromosome, and recently, which exactly in 1993, the exact location of the gene that's responsible for Huntington disease, which is Huntington, was located. We're going to talk about the epidemiology of Huntington disease. Huntington disease affects males and females equally because it's an autosomal dominant genetic disorder. In Caucasian populations such as in America and Europe, Huntington disease affects 5 to 10 individuals for each 100,000. In other populations such as Japan, China, Black African countries, there will be a major decline in the epidemiology of the prevalence of Huntington disease. In other isolated areas such as Venezuela, especially in Lake Maracaibo, the prevalence can be 700 cases for each 100,000 population. About the onset of the disease, Huntington disease is a mid-age onset. Its main range from 35 to 44 years. There are cases that are under 10 years or older than 70 years, but they are relevant. We're going to talk about the classification of disease. There are 2 main types of Huntington, which are the classical or the adult Huntington disease, which we are describing and discussing in this presentation. And there are the other type, which is juvenile Huntington disease, which is nothing but a more severe case of Huntington disease. Regarding juvenile Huntington disease, its symptoms are Parkinsonian features with mild or absent of chorea. Etiology and inheritance. As we said before, Huntington disease is an autosomal dominant single gene disorder. It's caused by an elongated CAG repeat on both chromosomes as we said before. CAG is a codon that codes for glutamine. So essentially, Huntington disease is a polyglutamine expansion disease. In normal Huntington gene, CAG repeat should be less than 26. But in Huntington's disease, the CAG repeat will exceed 35. And
CAG?
CAG, cytosine, adenine guanine. If the CAG or triplet repeat is between 29 and 35, this gene is called intermediate allele. Intermediate allele are unstable and they are susceptible to changes during reproduction. If CAG repeat exceeds 55, here we will have juvenile Huntington disease, which is, as we said before, a severe case of Huntington disease. The last thing about the inheritance and etiology of Huntington is anticipation. Anticipation is a phenomenon that we can notice in Huntington disease, which means that there is an increase in severity and decrease in the age of onset with each new generation. Regarding pathophysiology, before we start discussing pathophysiology, you should know that pathophysiology of Huntington disease is not fully known. We'll start by discussing the function of the Huntington protein. Huntington protein can facilitate vesicular transport, synaptic transmission, and play an important role in the transcription of neuronal genes. So, when there's an altered Huntington protein, this can really increase the ability or the severity of neurodegeneration of these cells. The main pathological feature of Huntington disease is neurodegeneration in the basal ganglia, especially in the caudate and glutamine, which is known as neostriatum. But other regions are affected, such as hippocampus, hypothalamus, substantia nigra, and other cortical regions. Pathogenic mechanisms of Huntington disease are many, such as excitotoxicity, mitochondrial dysfunction, which may lead to an abnormal energy metabolism, and also to apoptosis. Signs and symptoms of Huntington disease. Huntington disease have many signs and symptoms, as we said before. They are classified three main categories, which are motor, such as chorea, hypokinesia, rigidity, dysarthria, and dysphagia, which appears in later stages of the disease. The other category is psychiatric signs and symptoms, such as depression and anxiety, paranoia, and suicide, which is the second leading cause of death in Huntington disease patients. Lastly, cognitive signs and symptoms, such as loss of flexibility of the mind, loss of concentration, and loss of memory due to damage to the hippocampus. There are secondary symptoms which include weight loss due to dysphagia, as we said before, and irregular sleep cycle due to hypothalamic dysfunction. Now we're going to talk about, here we can see the prognosis of the disease. We can recognize that there is a functional ability decline with the onset of the disease. Until treatment a point or specific level, there will be a loss, complete loss of independency of the patient, and this is related to a high level of suicide at this time. Diagnosis of Huntington disease. Diagnosis of Huntington disease depends on personal and family history, clinical examination, and multiple lab testing. But the main confirmatory test is genetic testing, in which we are looking for the gene if it's mutated or not. The CT scan are also useful. If you can see here, there is a shrinkage in the basal ganglia due to sensitive neurodegeneration of the neurons in basal ganglia, as you said, and we recognize an enlargement in the lateral ventricles. Prenatal testing is also available via chorionic villus sampling between the 11th and 13th week. Treatment. As you said before, pathogenesis is not fully known, so there is no cure till now. But there are therapies for treating signs and symptoms or prevent complication. Many therapies, but they are generally classified into two main categories, which are non-drug-based treatment, such as specialized Huntington disease clinics or baggage chairs. The second category is drugs, such as tetrabenazine, which depletes the neurotransmitter in the nerve terminals, mood stabilizers, antidepressants such as hydrochloride, and antipsychotics such as chlorpromazine, which causes neuron depletion. Here are the main points that we have mentioned in this presentation. And lastly, if you want more info, I recommend you to check Huntington's Outreach Project for Education at Stanford, HOPES. It has really some valuable information. Any questions?
عندكم سؤال؟
تفضل.
شنو علاقة الإكزامين توكسيستي بالهانتنجتون ديزيز؟
إذا شفنا هنا محمد، هنا نشوف إنه البروتين الميوتيتد هانتنجتون بروتين حيسوي حيضرب الميتوكوندريا. نضرب الميتوكوندريا قلنا هو له دور تشكيل الميتوكوندريا، من حيضرب الميتوكوندريا حيصير عندنا. اللي حيصير عندنا الميتوكوندريا ما تشتغل، فمثل ما قلنا بالاعراض انه حيصير عندنا ابدومينال انرجي ميتابوليزم راح نعتمد على الانيروبيك ريسبيريشن، فحيزيد مستوى اللاكتيت. من زاد مستوى اللاكتيت هذا صار توكسين بالخليه. الشغله الثانيه اللي تصير انه من يصير عندنا اسكيميا، عندنا ريسبتر على سطح النيورون، ريسبتر خاص بالجلوتامين. من يصير اسكيميا ينفتح هذا الريسبتر، هو دائما بلوك يكون. من ينفتح حيجي الجلوتامين